Professor Cribier has received several scientific distinctions and awards in France, the United States, Argentina, and India, correct, for his pioneering work. And his topic today, and I hope this is right, transcatheter aortic valve replacement. Where are we and where do we go next? So ladies and gentlemen, please help us welcome to our stage Dr. Alain Cribier. Thank you so much. Yes.
Thank you. Well, good morning to everyone. I don't know if you can believe it, but it's already 10 years since we had the privilege of implanting the first transcatheter aortic valve in my institution, and we will celebrate that on the 16th of April this year. So it's a long way. And I have been asked this morning just try to summarize a little of the milestones that allowed to develop this technology, to tell you where we are today and, if possible, where we are going. So I am actually a consultant for Edwards Life Sciences. So I think it's good to go back to the baseline, you know, and to the concept. The original concept of TAVR was to replace the aortic valve using regular catheter-based techniques, if possible under conscious sedation, local anesthesia, in patients with severe aortic stenosis at high risk or contraindicated to heavy surgery and general anesthesia. And this development of TAVR has been a very, very long and tortuous and difficult way over, I would say, 20 years. So you have here the main milestones. You know, as you can see on the screen here at the bottom, you know, everything started in '85 by the development of balloon aortic valvuloplasty, which was the first technique that I proposed to treat patients who are not candidates for surgical valve replacement. And at that time, there were a number of patients because age per se above 75 was a contraindication for surgery, and the patients were left aside and died peacefully after 1 year or 2 years, and we could not do anything for that. So we dilated the valve, and there was a good functional improvement, but unfortunately, the results were not lasting. And finally, we had to find a solution to fight against the so-called valvular restenosis. And the idea that came to me was to implant a stent within the aortic valve and to place a valve inside the stent and to try to maintain the valve open. So first of all, we had in '94 to demonstrate that on post-mortem studies on cadavers, that the concept of stenting the aortic valve was okay, that it could maintain the valve open. And then during 5 years, I have been trying to find a company that would be interested to support the development of this project, but it was a complete failure. Nobody believed that it was feasible, and finally in '99, with some friends in the United States, we created a startup called percutaneous valve technology, and we could obtain the first prototypes of aortic valve. Then we started a period of animal implantations, a number of animal implantations. Then in 2002, we did the first human implantation of the aortic valve, followed, as you can see here, by feasibility studies. Then in 2004, our startup was acquired by Edwards Life Sciences, which was a big milestone. Everything was improved. We had the CE mark and commercialization of the product in Europe in 2007, and then we started post-market registry to finally get to the partner US pivotal trial, which was so important, randomized study. And in October of last year, the FDA approved the technology for patients who are not surgical candidates. So it's a real long odyssey of 20 years. And in parallel, we have the development of a concurrent valve, the core valve, which is starting in the United States, but already very, very much implanted in Europe. So in 2012, we can say that it's a success story since more than 50,000 valves have been implanted worldwide. For example, in Europe, more than 500 centers are open for this technology. We are planning, Edwards is planning to open 300 centers in the United States since they obtained the FDA approval. And today, we have more than 100 centers open already in the United States. So, you know, here, just to let you understand the way it works, and this was a very fundamental post-mortem study showing on the left the results of balloon aortic valvuloplasty. You know, not so much to show. You know, the valve is slightly open. You can observe that one of the leaflets has been broken. There is a fracture. And so the valve is a little more supple, but the aortic valve area remains below 1 square centimeter. Now, if we introduce a stent, at that time it was a Palma stent inside the valve, you can see that there is a full opening of the valve, and this was observed in any patients, whatever the amount of calcium. So this was really a positive aspect. But the most important was to cut the aorta longitudinal after the stent has been implanted. And you see what we could observe, that if we wanted to implant a valve like a surgeon in the subcoronary position, we had to pay special attention to preserving the coronary artery ostia of any coverage by the valve. And we also have to take into account the proximity of the intraventricular septum with the His bundles inside, and that I didn't want to crush, and the mitral valve insertion, which is very close by. And so we definitely concluded that the maximal height of the stent should be in the range of 14-16 millimeter, with a diameter that was underestimated by me, saying that 23 millimeter would be probably enough, but in the future we showed that it was not enough. So then you can see here the founders of the percutaneous valve technology startup, and the results obtained at the acute implantation of the valve in the sheep. We did more than 100 implantation in the sheep. And below, you can see the chronic results at 6 months, showing that the valve was intact. There was no calcification, there was no deterioration of the leaflets on these prostheses, and that the stent was very smoothly covered with a layer of endothelium. So this was very, very encouraging. In such a way that in April 16th, we did the first in-man implantation on a very special patient. As you can see, he was only 57 years of age. He was in cardiogenic shock. He was really dying. He had multiple comorbidities. He had 2 femoroiliac bypasses occluded. And so if we wanted to implant a valve to save his life, we had to improvise the transseptal approach coming from the femoral vein. So this was something extremely challenging. You can follow the yellow arrows on the left, showing that the valve was advanced through the femoral vein, crossing the intra-atrial septum, and then getting to the aortic valve. So this was really challenging. And you can see here the 3 people doing this first case. It was not very, it was a little stressful, I must say. And you can see here the valve implanted exactly where we wanted, at the end of that, in the middle of the calcium. And immediately we had a fantastic improvement of the hemodynamic, in this case, with the disappearance of the gradient. And at the same time, you can observe the drastic improvement of this very first patient, starting with a black guy, who had several cardiac arrests on the way to the cath lab, and 8 days later, it was a real resuscitation. So this was very important because from a single case, we could first of all demonstrate the feasibility of transaortic valve implantation. There was no valve embolization, no coronary occlusion, no mitral regurgitation, no permanent AV block, no aortic regurgitation, an optimal valvular function on echo, and an immediate hemodynamic and clinical improvement. So this was published in Circulation as a real breakthrough technology, and I must say that the reaction of the medical community was really amazing and very enthusiastic. So then we were allowed in France to do a series of patients. We did 40 compassionate cases using the same transseptal approach from the femoral vein, and it was extremely interesting. We developed a new valve, which is here, with 3 leaflets of equine pericardium inside a very sophisticated stent, which was very powerful, and we had a single size of 23 millimeter. So this demonstrated the feasibility of TAVI again, and we had several technical and clinical limitations of the transseptal approach, mainly if we wanted to spread this technique abroad, because the people were not really used to do a transseptal implantation. In 2004, we had the acquisition of percutaneous valve technology by Edwards Life Sciences, and then we enter a new world with the development of the new valve that you can see here, the Edwards Sapien valve, the same that you are today implanting in the United States, which is bovine pericardium treated with a special drug, Tetrafix, which is an anti-calcium substance. And the stent is stainless steel. There is a very, very powerful radial force, and the whole thing is covered by an external cuff to avoid paravalvular aortic insufficiency. And you see here that simultaneously, Edwards developed a technology to introduce the valve transfemoral and not transseptal through the femoral artery with a very interesting delivery system. and also at the same time through the apex of the left ventricle using what we call the transapical approach. In such a way, with the same valve, we could cover all the need, whatever would be the status of the femoral artery. So this was done mainly by John Webb for the retrograde approach, and Michael Mack, Frederick Moore, and Thomas Walter in Germany for the transapical approach. And also, the valve was produced in two sizes, 23 and 26 millimeter, covering more or less what we needed. So then, I show you here the number of studies done from the first in man to the very recent partner US pivotal trial, which is a big randomized study, which was so important. And you see here that we had several registries from Europe, Canada, United States, and this is the name of these studies that maybe you have read in the literature, and the number of patients included. But the most interesting part of that is that, as you can see on the left, we progressively moved from compassionate cases, it means dying patients with a spontaneous life expectancy of below 2 weeks, to progressively, after 8 years, reach a high-risk population. So this is extremely challenging. If you compare with what has been done with coronary angioplasty, it was exactly the opposite. We started with low-risk patients, for example, proximal LAD, and then progressively moved to high-risk patients after 8 years. So it's exactly the opposite. Just to say that developing the valve was particularly difficult and challenging. So we can be proud of the result today, I must say. You can see here the progress in the procedural success rate all along the European registries, starting with 85% of positive results in the transseptal approach to above 95% in the last registries in Europe. Like you heard probably of the Source registry, Partner Euro registry. At the same time, the core valve also had some registry showing the same excellent immediate results. So if we have here, I don't want to bother you with numbers, but just to say that in general, all the results in the different registries, Partner Euro, Source Registry, the series of John Webb in Canada, Vancouver, the series in France, and so on, and the core valve, showed that the results were not bad at all. On this population of patients with a life expectancy of only 20% at 2 years. We could obtain, at 1 year or 30 days here, but I will show you the results at 1 year, a very, very, very good survival, whatever the technique applied. And the stroke rate remains in the range of 3%. The implantation of pacemaker, because the septum was crushed, was excellent with the Edwards, really higher with the core valve, because the core valve is inserted deeply inside the left ventricle. And one of the issues was, of course, the vascular complications, which remains today one of the main issues. At 1 year, in the Source registry in Europe, you can see here the survival, which was unbelievably better than the spontaneous course of the disease without any valve, and this was later on demonstrated by the Partner US trial. And you see that whatever the valve implanted, whatever the route, the survival was above 70% at 1 year, which was considered excellent. So here, this is just a summary of this unbelievable randomized pivotal study that was done in the United States, where they selected the population of high-risk patients, and the decision was to know whether or not the patients could be operated on in spite of the risk. And if the patients could be operated on in spite of the very high risk, it was cohort A. If the patients could not be operated on because the risk was too high for surgery, then it was cohort B. So these patients were randomly assigned in cohort A, surgery against the transcatheter valve, and in cohort B, medical treatment alone against the transcatheter valve. So we were expecting a lot, these results, I can tell you. So in August 2009, the inclusions were completed, and you see that this study involved more than 1,000 patients in 26 centers in the United States, and the results were communicated and reported in September 2010 for the cohort B, valve against medical treatment, and in March 2011 for the cohort A, surgical treatment or valve, percutaneous valve. And these results have been absolutely unbelievably good. For example, here, if you see the results in cohort B, this is one of the most drastic examples of a difference in two strategies on randomized basis. 50% mortality, 50% survival, 50% death with the standard therapy, 30% death only with the valve at 1 year. And these results have been proven recently to be even better at 2 years, and this will be presented in the coming days at this meeting. And you have here the results of the partner A, where the transcatheter valve was compared to the surgical valve. And you see here that at 1 year, the results were very comparable. So this was, of course, a major information for the interventional cardiologist and surgeon, saying that in a patient who was high risk for surgery, you can select either the transcatheter valve or surgery, and then this is a personal discussion with the heart team to know exactly what to do. So with candidate for TAVI in 2011, it's very simple. Today we have to remain in the range of high surgical risk patients. It means logistic Euro score, predictive score of mortality after surgery above 20%, STS score above 10%. So this is a high population, high-risk population. I cannot enter into details. The scores are not perfect, but this is on what we are based today. And the patients with true indications to surgery, which is a personal decision of the surgeon that he cannot operate for many reasons, are also an excellent indications. Today we have also the possibility of implanting the valve if the patient is frail. I mean, this is not a quantitative assessment. This is just a question of good sense. There is a heart team. They have to discuss each patient and say, well, this old lady is a little frail, and probably if you can avoid heavy surgery for her, it would be better. But today, age per se and patients refusing surgery are not indications to TAVI. And again, a good clinical sense of the heart team is the key for all borderline cases. So where do we go? So today, we have been working a lot on improving the valve and the delivery systems, and you heard probably that many new valves are coming on the market. Secondly, we are ongoing registries in control trials in specific subsets of patients, for example, intermediate risk patients, not that high risk, and the so-called valve-in-valve for degenerated bioprosthesis, which is also a very interesting new indications for this transcatheter valve. We have to assess a little better the valve and platform durability, because this is one of the thing that we miss today to know exactly how long this valve will work. And also it would be great if we could work on the procedural cost and reimbursement, especially in developing countries, because this is a strong limitations for the development. But more or less we are going to an expansion of the indications. So, improved prosthesis. We have been working a lot with Edwards in improving the prosthesis. You see that we started with this first-in-man bovine pericardium valve, and then next generation, the equine pericardium valve, and then the Edwards Sapien, which is used today in the United States. And in Europe, for the last 2 years, we could use this new Sapien XT valve, which is unbelievably better. You can see here it presents in the semi-closed position. The stent is no more stainless steel, but in cobalt chromium, which is extremely resistant, even though thinner. And moving from the Edwards Sapien to the Sapien XT provided the possibility of decreasing the sheath size at the femoral entry site from 22-24 French, which is quite big, to 18-19 French, which is a very, very big progress. And more or less, this valve is excellent, and it is a real duplicate of the Perimount Magna valve that is implanted by the surgeons, inserted within a short stent. So there are a lot of arguments to think that the long-term durability of this valve would be as good as the surgical valve, and I will show you why we can think about that. We have also extraordinarily improved the delivery system. This is a Retroflex 3. You know, the valve is crimped over the balloon here, and this is the one which is used in the United States today, the only one. So big sheath size, 22 French, 24 French, needing more or less a cut down of the femoral artery under surgical approach. And now in Europe, we have been using for the last 2.5 years, the NovaFlex delivery system, where the valve is not crimped over the balloon like this, but over the shaft of the catheter, and the valve is placed over the balloon when inside the abdominal aorta. And doing this unbelievable, genial system, this has allowed to decrease the size of the device to 18 French and 24 and 19 French. The delivery system, which is coming also, is very bright, which is an articulated delivery system in such a way that when you are crossing the aorta, you are not touching the wall of the aorta, decreasing the risk of dislodging a plaque at the level of the carotid arteries. And you see here the difference for the same valve size, 22 French, 18 French, so it means that in the majority of patients today, we can use a stent-like procedure. This is what is done in my department. Can you imagine that we are implanting a valve like we are implanting a stent? Local anesthesia, pure percutaneous approach, decreased vascular complications because of the decreased size of the sheath, and the patients are discharged after 2 or 3 days. You know, the patients come with a lot of symptoms, they are sometimes dying, and 2 days later they are back home without any cardiac rehabilitations need. So this is a tremendous progress. And today, with a decreased sheath size, we can use the transfemoral approach in 80% of cases. And you see here, for example, this is in my institution. There is almost nobody around the patients. We have only 2 interventional cardiologists. We have 2 nurses. One nurse is also dedicated to crimping the valve, and the other nurse is dedicated to doing the rapid ventricular pacing, which is done for implanting the valve very safely without any movement of the device. On the same thing also interesting is the progress done by the core valve, you know, starting with big-sized devices in 2004, to move to smaller device like this one, quite elegant. And in 2011, they have also improved a little the device to facilitate the positioning across the aortic valve. And this valve is also inserted using percutaneous techniques, local anesthesia, and pre-closing of the femoral artery with a ProStar. So what is the ideal candidates for TAVI? We have here the clinical evaluation. We have to check whether the anatomy is suitable, and we have to select the access. So this is a cooperation of many people, echocardiographer, catheterizer, and a CT scan, and we have to assess, of course, the diameter of the annulus, the distance between the native valve and the coronary artery. We have to check the aorta on CT scan, and we have to check eventually on CT scan the distribution of calcium. So this is a very big job, and also we have to make sure that we can introduce the valve using the transfemoral access, as you can see here, using cross-section on CT scan, which is extremely important. So just to see to show you the way it works, we are pre-closing the femoral artery with a pre-closed system. The valve positioning is done extremely simply by using this sinus inch point line, and the valve is placed 50% above, 50% below. And you have here, can you click on the video on the left, please? I don't know whether I will be able to show you that because I don't have any possibilities of using the slides. No. This is now the valve implantation using the transapical approach, where the purse string is done at the apex of the ventricle, and again the valve is introduced directly through the ventricle, left in place at the aorta, and you can see here the valve delivered, but unfortunately I cannot show you the video because I don't have anything to work on that. So now we have also a new approach, a trans-aortic for the surgeons. In comparison to transapical, we can also go directly through the aorta, which is extremely elegant, bright. You know, the entry site on the aorta is here. Only 3 centimeters below you have the aortic valve. So this is also something great. Now, just a few slides to show you where we go. You see here the increase in valve implantation in France, for example. In the French registry, you can see that it looks like an exponential curve. And there is a trend today to increase the number of TAVI procedures in Europe and to decrease the Euro score. Today, most of the patients have a Euro score which is just above 15%. So this is a big progress. Now, if we want to move to the future, just to make possible to propose this valve in younger patients, lower risk patients, we have to make sure that the transcatheter valve compares favorably with surgical bioprosthesis. We have to compare the results of surgical bioprosthesis and the valve, and also we have to know a little more about the long-term durability. Just to make it short, you see here that the bioprosthesis that we are implanting and the surgical valve are really comparable. 92% perfectly circular. the implantation of the valve is perfectly subcoronary, in the subcoronary position, like a surgical valve, and more or less, these two valves are strictly comparable. So I wonder why the results should be different on long terms. Now, if we want to compare the results, we have now the partner A results of the US study showing that the results are comparable at 1 year, so this is good. And concerning the durability of the valve, we don't have too many data, but at least up to 2 years, there is absolutely no change in the decrease in gradient and the increase in valve area. And in my center, since we started in 2002, we have unbelievably long follow-up. For example, here, 6.5 years of follow-up without any dysfunction of the valve. We have some other issues that we have to make sure to demonstrate, to improve maybe in younger patients, for example, aortic paravalvular regurgitation, but actually it's almost totally solved by a better screening of the patients, checking the anatomy of the valve and so on, adapting the valve size to the annulus size. So we know what to do to improve this issue. And the permanent pacemaker is also an issue in younger patients, but you know that with the Edwards valve, this rate of pacemaker is relatively low in comparison to the Edwards, and it's almost always due to a low positioning of the valve in the left ventricle, so we know today how to avoid this. Here that the Edwards valve is not reaching the intraventricular septum on CT scan, and so this is why we have a very small amount of permanent block. So we have also to improve the rate of vascular complications. We are working on lower size devices, improved closure devices, an optimal screening of the patients by doing a CT scan in all. So we know what to do for that. And concerning the stroke rate, we have today to study the availability of using protection device like filters, and we will have some special randomized studies starting in Europe to evaluate whether the filters can solve the problem. So it's not time yet to move the indications to younger and less sick patients, but it's time to evaluate new indications by randomized study versus surgery in lower risk patients or control registries like those who are ongoing in Europe. CERTAVI, the partner 2 trial in the United States with the STS score is only above 4% and so on. So we are moving in the good direction. So there is also this fantastic new indications of implanting the valve in degenerated bioprosthesis. You can see here, this is the result. You can see the valve is inside the other one. And so with excellent result that I can just summarize at the bottom, here, this valve dysfunction with a high gradient, a very low diastolic pressure. And after implantations in valve, everything is totally normalized. So this is also the future. And we have many other valves coming on the market, but we have a lot of interrogation mark, about the long-term durability, repositionability, better platform, better valve. We don't know anything about that, so this is the beginning of the story. So in conclusion, as you see, developing TAVI has been a long, tortuous road, fantastic, unbelievable experience, and the story is ongoing. This year, with technological advancement, there is no doubt that the number of centers and procedures will continue to grow up in high surgical risk patients. Within 5 years, we can really expect an expansion of indications to some other subsets of patients, like less severely younger patients, less invasive procedures, stent-like, may be used in over 70% of the cases. Within 10 years, we don't know where we'll be. TAVI might be used in the vast majority of patients with severe AS. The future definitely looks bright. And this is just a wink to the negative comments of all the experts between 1994 and 2002 when they say that it was the most stupid idea that they have ever heard. Okay, thank you very much for your attention. Thank you.
Thank you so much, Dr. Cribier. I don't know what your schedule is. If you have to be somewhere, do you have time for a couple questions or no?
Yes, I have time for questions. And also, I can announce that there is a video film of a procedure that you can see. It has been a recorded case in my center, a live case. So if you are interested, you can see a case just after that.
Very good.
If you have any questions, you are welcome.
I have one right back here. I saw this gentleman first.
Could you describe the anticoagulant or antiplatelet therapy after your valve implantation?
I'm sorry, can you repeat the questions because I cannot hear it from here?
Antiplatelet or anticoagulant?
Yes, well, yeah. Well, the anticoagulation treatment is an issue today. So we are starting on the basis that we use the same strategy that for a bare metallic stent. It means that the patients are loaded with a combination of aspirin and clopidogrel just before the procedure, and then they keep these dual platelets, antiplatelets treatments for 1 month, and then the clopidogrel is stopped and they go on aspirin. So this is what we are doing today in Europe, but we'll start a randomized study just to assess whether 2 platelets, antiplatelet drugs, or 1 antiplatelet drug is enough. And personally, I think that 1 antiplatelet should be enough in the future, but no anticoagulation.
Good morning. I have 2 questions for you. The first one is, when the trans-aortic approach is done, that has to be done under general anesthesia?
Yes, of course. Yes, all the minimal invasive surgery, transapical or transaortic, is obviously done under general anesthesia in the OR by the surgeons.
And the axillary?
The
axillary.
The axillary approach is not used for the Edwards valve. It's used only for the core valve. But more or less, there is a trend to move from the axillary approach to the transaortic approach, which is really more elegant and safer.
And the second one is this change from equine to a bovine valve. How did that happen?
Yes, it was just for a question, industrial reasons. The bovine, I think that the major interest of the bovine pericardium valve is that we have all the results of the surgical valves. The bioprostheses are made of bovine pericardium, so we know a lot about bovine pericardium, and so it's a safety net, for the patients, because we know that after 15 years, these valves are not degenerated. This is why it's a big advantage in this bioprosthesis to use the same pericardium that the one used for surgery.
Very nice talk. Thank you.
Thank you.
Could you comment on expansion to the use of this type of valve for AI, aortic regurgitation?
Yes, well, actually, this is an interesting question and issue, but in fact, AR is very special because the aortic annulus is larger, and so it's not a piece of cake, to increase the valve size from, for example, 26, 29 to 35. It's a big challenge for the engineers. And also, if we don't have any calcium, any fibrosis on the native valve, there is nothing to anchor the valve. So the risk of migration would be higher. So at the present time, there is no optimal solution for aortic regurgitation, pure aortic regurgitation.
Have you seen any late calcific degeneration?
Never. So this is clear. Clear question, clear answer. Up to more than 5 years and from several patients.
Hi, one question. The transeptal approach is so difficult that the retrograde approach?
Well, the transeptal approach was the only possible approach at the time when we started because of the size of the sheath. So it was always feasible to introduce the valve to the femoral vein, because in the femoral vein, you can place a sheath that big without any problem. So this is why we started that. So we solved almost all the issue of the transeptal approach over 2 years. But in fact, we realized that using the transeptal approach, it was not possible to spread the technology to many centers, because a few centers were really able to do the transeptal technique and so on. And so we had some specific complications related to transeptal that we solved. We solved with time. And today, we would be able to start again. I have met yesterday Bill O'Neill, who was one of the first doing the valve implantation in the United States. He said to me that he recently did 2 cases using the transeptal again, because the patients were not possibly implanted through the transaortic transfemoral, and it was impossible. So it will come again for a selected subset of patients, very selected, because it's much more difficult.
And please, do you think that is essential to have a TEE, transesophageal, during the procedure? This is one question. And in your opinion, which is the best way to measure with the images before to choose the
I will answer your questions, but I can tell you we can sit and stay the whole morning on that, because it's a question, coming back all the time, and there are heavy discussions concerning the measurement of the aortic annulus. Today, measuring the aortic annulus is mainly done before the procedure using transthoracic echo, transesophageal echo, or CT scan. And the results are totally different. So what I am suggesting today is to use the so-called balloon sizing, which is extremely elegant. It means that when you don't know exactly which valve size you want to implant, you inflate a balloon of a given size, and you see, you do an angio at the same time when the balloon inflated. You see whether you have an aortic regurgitation or not. You can compare the balloon size and the aortic size and so on. This is absolutely perfect. Now, transesophageal echo can be used during the procedure, not only for valve sizing, but to check the results, to assess the valve positioning, and so on. Personally, I'm not using it because I cannot, the advantage of doing local anesthesia and sedation in comparison to transesophageal echo, which requires general anesthesia, is not fair. For the patient, it's much better to have a local anesthesia sedation. And actually, during the procedure, to me, this is my opinion, transesophageal echo is not extremely important.
Do you have any experience with bicuspid valves?
Yes, bicuspid valve, we of course, we did some bicuspid valve, but it depends on what you call bicuspid valve. We have the true congenital bicuspid valve, these two pieces of rocks, working like this, that the surgeons know very well, in patients who are younger, 65, 70 years of age, true bicuspid valve, not a good indication for this procedure because the bicuspid valve prevents the stent to expand perfectly well, and also created some risk of paravalvular leak in the commissures. So more or less, the true bicuspid valve is not a good indication. Now, we have the fake bicuspid valve with raphe, 1 or 2 raphe, something which is very frequent in the elderly population, and this is a good indication. There is no limitation at all.
2 more questions?
Sure.
Okay.
I think some of the new valve, like the St. Jude valve, can be repositioned. Is that correct?
Well, actually, as you have seen, I was short because I had to rush, but many valves are coming on the market, and one of the potential interests of these valves are that they offer the possibility of being repositioned. If you are not satisfied, you can remove it, place it a little higher, lower. That's okay. That's okay. But in fact, with if you have an experience of an Edwards valve, it's a very, very minority of patients where you are not satisfied today of the positioning. We have a clear-cut landmark, which is quite new. At the beginning, when we implant the Edwards valve, we were trying to place the valve in between the calcium, more or less high, low. We didn't know exactly. Today, we use the sinus inch point, the base of the sinus. Place the valve 50% above, 50% below, and you will never be disappointed. So it means that the fact of being repositionable, to me, is not a major advantage. But, well, if you are not satisfied, if you can remove the valve a little, it's not bad. But this is just a very small point in comparison to the durability of the valve, precision of implantation, the hemodynamics, and so on.
And I believe this will be our final question here.
Okay. And in these old patients and extremely calcified valves, what do you have about paravalvular leakage and mismatch expect?
Yes, absolutely. Well, to avoid the mismatch is really one of the main goals when we are screening the patients, and this is why I was explaining that we cannot be satisfied only by thoracic echo, transesophageal echo, CT scan, because if we want a perfect mismatch, the best is to be a balloon sizing, because when you inflate the balloon and when you do the angiogram, with a given size of the balloon, you know exactly what will be your result. So if you have a leak on the side of the balloon, of a 23 millimeter balloon, for example, if you place a 23 millimeter valve, you will have exactly the same leak. Of course, in elderly patients, the valve structure is very complex. And so we can have some gaps between the calcific nodules. There is something that we cannot avoid. But there is a new valve coming now that we call the Sapien 3. That has been absolutely aimed at fighting against this paravalvular leak. And I am sure that next year, we will have the solution to all paravalvular leak with this new device.
All right. I think that's all the time we have for questions now. How about another thank you for Dr. Cribier? Been very generous with your time with us today. Thank you so much.